Hey guys, how you guys doing? Welcome to another Lit Review, where I dumb down scientific journal articles to my level. So today, the journal that we'll be talking about is from a Journal of Bone and Joint Surgery, JBJS, and the title of the article is Treatment of Acute Achilles Tendon Ruptures, a Meta-Analysis of Randomized Controlled Trials, and it is written by Dr. Khan, Dr. Fix, Kyo, Crawford, and Teen Brummer, and Martin Parker. This was published in 2005, and I think from this meta-analysis, more of the recent treatment protocols for Achilles tendon is derived from it. And Achilles tendon is it's pretty not common, but is one of the is in terms of the foot and ankle injuries is top 3 of the injuries that is involved in the Achilles tendon itself. Not necessarily the rupture, but it's pretty common in the lower extremity injuries. And the Achilles tendon, as a quick review, is made up of initially three tendons: gastrocnemius from the femur, originating from femur, inserts into the calcaneus. Same thing with the soleus, but soleus originates slightly a little bit more distal, starting from the tibia, comes out. And then the medial and the lateral head of gastroc and the soleus makes up the triceps surae, the three tendon structure that becomes tendinous around this part of the leg and inserts into calcaneus. And it's one of the strongest tendons in the body. I think it could be the strongest one. And it just runs a straight path to it. And generally, the Achilles tendon rupture most commonly happens in this area, where basically not the muscle part, but after the muscle part, after the myotendinous junction of the Achilles, the posterior part of the leg, and a little bit proximal to the insertion of the calcaneus, and that zone is called zone 1. And generally, with like other injuries, other like bursitis or retrocalcaneal bursitis, for example, those injuries are in zone 2 over here, and then the myotendinous junction is zone 3. I think so, pretty sure. So zone 1 is the general area where people rupture their Achilles, and the way you rupture your Achilles is by when you're extending your knee and kind of dorsiflexing your ankle. So an eccentric dorsiflexion of the ankle kind of put too much pressure or tear or strain on the Achilles tendon, and it kind of ruptures it. So basically a forced plantar flexion or unexpected dorsiflexion. And people often describe Achilles tendon rupture as someone kicking the back of your leg, and oftentimes there's tons of videos out there in YouTube where you can see professional athletes with their, like especially soccer players, when they rupture the Achilles tendon, they turn around and check if someone kicked them in the heel. And most often, there's no one there. It's just a sensation that someone's kicking them that kind of tells them that it's a tendon rupture, essentially. And so those are the athletes, but for those most commonly in clinic setting and hospital settings, the people who will be rupturing the Achilles tendon are generally male. It's about 6 times more frequent in male than female, and also those 30 to 40-year-old male that kind of go out on the weekend and do extensive activities. So like weekend warriors are often gonna be the one rupturing their Achilles tendon. Like maybe they're sedentary most of the days, working throughout the week. But on a weekend, they could go out and play basketball or play soccer or something like that. Then often they'll rupture their Achilles tendon. And the reason why it's 30 to 40 years old is because the tendons start, the vascular, and then the vascular kind of stops at 25 or so. So early 30, you're going to have the blood supply. Vascular growth, I think, is going to start degenerating in the Achilles tendon. So once the vascular area starts getting weaker in a sense to the Achilles tendon, especially in the Achilles tendon insertional zone over here, which we call the watershed area, which is 2 to 6 centimeters proximal to the insertion, that's the weaker point. It dries up the area of it, because the blood will kind of moisten and provide nutrient and all that stuff to the tendon area, but if the watershed area, which is lack of reduced amount of vascular compared to the other area, will be weakened. So that's where the most common rupture will occur. The watershed area, kind of in the zone 1 area, like we said earlier. So that's basically the background of Achilles tendon. So now this paper is a meta-analysis, meaning they take they sift through a whole bunch of research database and pick randomized control trials to see the success rate of Achilles tendon repair. There are a couple ways to treat Achilles tendon rupture. One way is conservative, just like you put them in a cast and immobilize this and hope for the best and hope the Achilles tendon will heal on its own. And this is generally recommended for patients who are kind of old and sedentary and who are not really active, and I don't want to say not really need the use of the Achilles tendon, but the sedentary lifestyle, kind of old people who can have more risk going into surgery. And for the rest of the population who are a little bit more active, who are younger and who rupture their Achilles and are healthy, they will want to do a surgical option. So a traditional way of repairing Achilles tendon rupture is just making an incision down the foot posteriorly and bringing the ends of the Achilles tendon and then suturing it, making a pretty tight suture from the end to end. And there are different methods too. I think in surgery I saw a Krakow method where basically you get a stump of one proximal end and then get a different suture at the stump of the distal end, and you just tie the sutures together. So that's the traditional open way. And there's also surgical, but not necessarily open, like where you cut the whole incision, but you could do a percutaneous where you use this like a U-shaped device where you basically put it under the skin with you start with a small incision, you put it under the skin, and you basically suture percutaneously through the device, and once you pull the device out, all the sutures are basically embedded in the Achilles tendon. And it's more of a newer approach to fixing Achilles tendon, a little bit more advanced. So those are different ways. So what the study is doing is taking a bunch of these randomized, already published journal articles that compared different ways to treat Achilles tendon, operative, non-operative, or post-operative casting versus functional bracing, or and they were looking at wound complication and post-op complication and trying to determine which way is the best way to treat Achilles tendon rupture. So what they did was they sifted through a whole bunch of journal articles, and they found 12 random trial studies, which include total about a little bit over 800 patients to examine. And their exclusion, they didn't include obviously just any paper that was talking about Achilles tendon rupture repair, but they excluded some of them that had insufficient reporting of primary outcomes or inadequate methods that really didn't warrant a systematic fixing repair of the Achilles tendon. And they also excluded delayed presentation, meaning if a patient ruptured the Achilles tendon and they came into the ER after 4 weeks to get it repaired, they excluded that because there's going to be some more of a degeneration of the tissue that's going to be different from when a person acutely ruptures their tendon and comes to the ER and fixes it right away. So I think the delayed presentation was and it has to be less than 3 weeks of the rupture. And they also excluded any re-rupture. So repairing of a re-rupture to Achilles tendon did not count because there's already an underlying factor that may have exacerbated the situation, and the post-op complication will be different for a re-rupture repair versus a acute Achilles tendon repair. So they looked at 12 studies, randomized controlled studies, and which include about 800 patients, and then they just compare side to side the factors they wanted to see, and I'm going to be talking about those in each factor with the numbers. So one of the first thing is they compared just an open operative versus non-operative. So open operative operation includes the traditional way using the Krakow just tendon or the Kessler or whatever, bringing the end-to-end anastomosis of the torn tendon, or it could be percutaneous. So open operation includes both of those, and then that compared to the non-operative, non-operational, meaning casting method. And what they found out is that what they found out in the research is for an open operation, the re-rupture rate. So you want this rate to be super low because you don't want it to re-rupture after you fix it. So the re-rupture rate for open operation was 3.5% versus 12.6% in a non-operation. So meaning non-operation fix an Achilles tendon repair is you're gonna get a significantly more re-rupture compared to the open operation. And however, the caveat for this for the open operation, despite the re-rupture rate being so small, the complication is greater in the open operation. The overall complication, excluding the re-rupture, was 34% versus 2.7% against when comparing to the non-operation. That kind of makes sense because when you're cutting someone open, you're making a trauma to the skin. You're making a direct trauma to the skin, incision, and so there's going to be some other complications because the tissue has to heal, versus a non-operational treatment where you're literally just kind of stabilizing it. So it's kind of expected that the complication for an open operation is higher than the non-operation, and you can see that from the number 34% versus 2.7% against the open operation. And then the wound complication for the open operation is 4%, and then the non-operational repair was 0%. That makes sense because you're not making any trauma to the skin, so there's no way a bacteria could get in and infect the skin. So that's the comparison. So despite open operation having a lower re-rupture rate, the complication is a lot higher. Now, within the open operation, they looked at the traditional method versus the percutaneous method. And there is no difference in re-rupture rate of either of those methods. So you could technically fix the Achilles tendon rupture using either of those methods. And I saw the Kwanoo method, like I said, and the percutaneous. My friend got the percutaneous rupture repair done, and I think the patients do fine in either of the cases. Now, but for the open operation where you make a incision posteriorly, and you bring the proximal and distal end together and suture it up, the complication for that was 26% compared to the percutaneous operation, which was 8.3%. Again, that kind of makes sense because percutaneous is just making a small incision and using a device that is designed to cause minimal trauma to the tissue. So the complication, the less trauma you cause, the less complication that's going to occur. The wound complication for the open operation was about 19.6% versus 0% against the for percutaneous. I don't know about the wound complication, wound infection being 0 for percutaneous. 0 is 0 and 100 doesn't really exist, and I feel like it shouldn't really exist in science journal articles. Those are basically extreme ends. So I mean, yeah, 0 meaning it signifies that percutaneous operation has extremely reduced rate of wound infection. And for post-operative splinting, after you do the surgery, you need to kind of put the foot into position, not just dorsiflexion or perpendicular to the leg, but you need to have somewhat of a plantarflexion to kind of allow the tendon to heal. So when they do a post-operative splinting, they compare the re-rupture rate in a cast versus functional brace. So in the cast, the re-rupture rate was 2.3%, and then functional bracing, the cast was 5%, and the functional bracing was 2.3%. So the functional bracing was lower percentage versus the cast in the re-rupture rate post-operatively. And functional bracing is basically, it's still immobilized like a cast, but there are hinges across the bracing that allow some sort of movement within the ankle joint. And the overall complication for the functional bracing was 19%, and for the cast it was 35%. And of the complication they talk about is like a tissue adhesion and such. So as a result, it's pretty straightforward. When you have a Achilles tendon rupture, you want to do surgery because that will give you almost like a guarantee to fix the Achilles tendon rupture. And afterwards, you want to put them in a functional bracing to allow some sort of more movements and allow the tendons compared to the casting, because it just allows better healing process for the Achilles tendon. People might argue, you know, the complication or the wound rate for the open repair is high compared to the casting or non-operational treatment for Achilles tendon rupture. But I think personally, I think you still want to go through the surgery, especially a lot of times you're gonna be young, because like I said, the mechanism, mode of injury for these are activity. So you were doing some sort of activity to injure yourself, and doing a surgery will allow you to quickly return to the activity that you want to do. So that was the gist of this paper. It was a lot of numbers, just comparing numbers, because like I said, this is the meta-analysis. Just looks through a whole bunch of databases to pick out the journal articles that are relevant to the topic, and the authors here basically compiled everything and came up with a summary. And a lot of times I feel like these papers establish kind of the treatment plan or the standard treatment for the current method of care. So I hope you guys enjoyed this video. I'm gonna try to do more of these videos for you guys, and again, thanks for watching, and stay tuned for the next video. Thanks, guys.